Hello, I'm seeing Heather. She's a 22-year-old female. She reports that chief complaint of, I think I might have a bladder infection. She reports dysuria at the onset of urination acutely for 3 days, where she has experienced dysuria and frequency. She attributes the frequency to increased fluid intake in an effort to clear the infection. She first noticed the symptoms when she was playing volleyball in the hot sun in August. She does deny urinary urgency. She admits to a poor fluid intake during that time period. As far as medical history, she did have a UTI with similar symptoms about 2 years ago. She did have a history of chlamydia at age 16. Past surgical history includes a myringotomy with a tympanostomy. What sounds like, she states she had tubes, so it sounds like that's what she had at 18 months old. She had a mole removal from her leg at age 12. She does not report any other chronic illnesses or significant family history related to her symptoms, and those are her subjective findings. Her social history also in subjective findings includes working as a waitress and a babysitter. She smokes about a half pack per day of cigarettes. Under review of systems or additional subjective findings, she does deny nausea, vomiting, diarrhea, or constipation. She is sexually active with her boyfriend. She uses condoms sometimes, but states that she doesn't use them every time. She is on birth control, but she misses her pills about 1 per week. She has had some vaginal irritation that she attributed to the change of the condom brand that she was using. She reports no recent STD testing. She does deny recent antibiotic use. She states she did have a slight, possibly white vaginal discharge. On physical exam, her objective findings reveal a slender, afebrile female and no acute distress. Her abdomen is soft. She does have mild suprapubic and lower quadrant tenderness bilaterally. In-house laboratory findings reveal a urine dip with large leukocytes, a specific gravity of 1.010, otherwise normal. My differential diagnoses include pelvic inflammatory disease as number 1, caused by chlamydia, which I suspect due to the vaginal irritation, the suprapubic pain, the lower abdominal pain, the white discharge, and history of chlamydia and unprotected sex. My second differential will be urinary tract infection. Due to her symptoms of dysuria and frequent urination, I feel this is less likely due to her lack of hematuria on her urine dip and no urgency noted. My third differential would be vaginal candida, which is suspected due to the vaginal irritation and the white discharge and the leukocytes noted on the urine dip. This, I believe, would be less likely due to no report of a thick white discharge and no report of excessive pruritus. My question to you regarding further testing. Do you feel that a UA would be warranted, although the urine dip in the office only showed the leukocytes and the specific gravity of 1.010? Also, would chlamydia testing be needed from a vaginal cervical culture? And I'm also wondering whether we should set her up for a pelvic exam to assess for cervical tenderness and friability to further investigate the PID. I would also like your opinion on treating for the PID empirically due to the consequences of sequela such as sterility, scarring, or life-threatening tubal ovarian abscess. So I'm wondering if we should just go ahead and treat her go ahead and start her on antibiotics for that regardless, pending the testing. A case-related issue for additional learning on my part would be including research on the first-line treatment for STDs, including gonorrhea, chlamydia, herpes, and considering treatment before lab results are in, or should the treatment be started after the lab results have returned? Thank you.